जी, अस्सलाम वालेकुम क्लास। हाउ आर यू? आपको मेरी आवाज़ सुनाई दे रही है? जी, अस्सलाम वालेकुम क्लास। आप सबको मेरी आवाज़ आ रही है? अच्छा, मुझे ये बताएं कि हमें न्यूरो एग्जामिनेशन में हमारा क्या बाकी रहता है? मेरे ख्याल न्यूरोलॉजिकल सिस्टम असेसमेंट में कल जब आप क्रीनियल नर्व्स असेसमेंट कर रहे थे, तो सिर्फ 2 स्टूडेंट हमारे साथ थे, मेरे साथ थे, और वो सादिया और सिद्रा जमील थी, अगर मैं गलत नहीं हूँ तो। आप लोग इतने बिज़ी हैं कि आपके टीचर्स आपके लिए बैठे हुए हैं और स्टूडेंट्स के पास टाइम नहीं है। तो फिर आप एडमिशन क्यों लेते हो इस डिप्लोमा में या अपनी स्टडी को? अगर प्रॉपर टाइम ही नहीं देना तो क्या फ़ायदा? ठीक है, मिस्टर रोनाल्ड हैं, उनसे रब्ता करें। जूलिस हमेशा लेट होता है और हबीबा वान हमेशा लेट होती है। इफ़रा तो उनको मैं क्या कहूँ। ओके, हमने क्रेनियल नर्व्स एग्जामिनेशन की पढ़ना है या वीडियो देखनी है? ऑब्वियसली वीडियो भी देखी जाएगी और पढ़ेंगे भी सही। नो वीडियो सर। आसमा खान, नो वीडियो सर, इसका क्या मतलब है? नो वीडियो सर, नो वीडियो सर, इसके 2 मतलब है ना। नो वॉइस।
Hello, I'm Dr. Abbott. I'd like to examine the nerves around your face and head. Would that be okay with you?
Yes, of course.
At this point, I'm making observations of the patients to see if I can see any abnormality in the cranial nerve distribution. This might be something like ptosis, strabismus, lack of facial expression, salivation, muscle wasting, or facial asymmetry. The first cranial nerve is the olfactory, which is responsible for the sense of smell. Have you noticed any problems with your sense of smell?
No.
If the patient complains of anosmia or taste abnormalities, these can be explored using a smell testing kit. The optic nerve is the second cranial nerve. The tested components are visual acuity, visual fields, and fundoscopy using the ophthalmoscope. I will test visual acuity first. If the patient wears spectacles, then testing is done with the patient wearing them in order to correct any refractive errors. I'd like to test your visual acuity. Can you tell me whether you wear spectacles, please?
No.
No. Okay, I'd like you to read some print off here. Could you take that in your hand and cover up your right eye, please? Could you read the top line?
He moved forward a few steps. The house was so dark behind him, the world so dim and uncertain in front of him.
Okay. Could you swap eyes and hands now, please?
Then he heard a sniff, felt something warm against his leg. He had almost stepped upon the animal. He bent down and stroked its wet coat.
Okay, that's great. Thank you. I've just used a specialist chart which is likely to be available in a special clinic. If you're doing the testing at the bedside, something like a magazine or a book would suffice. If you do find an abnormality of visual acuity, then you may choose to use a Snellen chart in order to quantify the defect further. I'm going to test your visual fields. Could you cover your right eye with your right hand, please? Now, I'd like you to look and concentrate in the centre of my eye. And I'm going to bring my finger in, and when the finger moves, I'd like you to say yes.
Yes. Yes.
When I'm doing this, I'm comparing the patient's visual field with my own.
Yes.
Okay? Could you swap eyes now, please?
Yes. 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 Yes.
If an abnormality is detected, a formal visual assessment by perimetry or central field assessment could be organised. For fundoscopy, it's best to dim the lights in order to allow the pupil to dilate, and to ask the patient not to look directly at the beam so that the eye stays in a fixed position. I'd like to examine the back of your eye using the ophthalmoscope. What I'd like you to do, please, is to look behind me at the clock and focus on the clock and not look straight at the light. Please notice for doing this, I'm using the ophthalmoscope for examining the patient's right eye in my right hand, and I'm going to look into his right eye through my right eye. First of all, I'm going to examine the red reflex. I'm now going to move closer to examine the back of the eye. I'm looking at the optic disc, I'm looking at the vessels, and I'm now going to scan the rest of the retina. I'm now going to move to look in the left eye. I'm going to swap the ophthalmoscope into my left hand, and I'm going to examine the patient with my left eye, looking at his left eye. Again, if you could look into the distance, please. Again, check the red reflex, and then examine the back of the eye. The cranial nerves 3, 4 and 6 are usually examined together. The tested components are the ocular movements and the pupillary reactions. First, I look at the ocular movements. I check at the normal resting position of the eyes and then at the full range of movement. Right, I'm going to test the movement of your eyes now, please. What I'd like to do is get you to focus on the tip of my pen. I'd like you to follow with your eyes and keep your head still. I'd also like you to tell me if you see double at any position.
Right.
Okay. So if you could just follow my pen. I'm taking the patient's eye movements to the extremes of horizontal gaze first. I'm then examining vertical gaze. At all stages, I'm looking to see if there's any nystagmus in any particular position. I'm now going to test for the movements of the oblique muscles. Okay, so you didn't see double in any of those positions?
No.
Looking at the individual nerves in turn, the abducens innervates the lateral rectus muscles, which are responsible for abduction of the eye. When the patient has a left sixth nerve palsy, the lateral rectus muscle will malfunction. When the patient looks horizontally to the left side, the left eye will not abduct normally. The patient will complain of double vision, and the images will be horizontally displaced. The trochlear nerve innervates the superior oblique muscle, and its action is demonstrated by asking the patient to look downwards and inwards. With a left fourth nerve palsy, there will be a weakness of the left superior oblique. When the patient looks downwards and inwards, they will complain of double vision with oblique displacement of the images. Because the double vision occurs on looking towards the right, the patient tends to feel that there's a problem with the right eye rather than the left. All of the other eye movements involve the oculomotor nerve. This nerve also innervates the vata palpebrae superioris, where weakness will result in ptosis. In the full picture of a third nerve palsy, the pupil will be dilated and the eye will deviate downwards and outwards. Can you follow the pen again, please? As the eyes converge, both pupils are seen to constrict. The light reflex involves the perception of light by the afferent fibres of the optic nerve, with the efferent parasympathetic fibres carried by the third nerve. Now I'm going to shine a light into your eyes. I'd like you to look out into the distance, please. I'm going to test the direct and consensual light reflexes. In the direct reflex, I shine the light in the right eye and the right pupil constricts. I shine the light in the left eye and the left pupil constricts. When testing the consensual light reflex, I shine the light in the right eye and the left pupil constricts. I shine the light in the left eye and the right pupil constricts. The fifth nerve, the trigeminal, has both sensory and motor components. Light touch sensation is tested in the ophthalmic, maxillary and mandibular divisions. I'm now going to test the sensation on your face. I'd like you to tell me if it feels the same on each side.
Yes. Yep. Yep.
The corneal reflex involves afferent fibres from the ophthalmic division of the trigeminal nerve and efferent for the facial nerve. If incorrectly I touch the insensitive sclera, no response occurs. When correctly I touch the cornea, a bilateral blink response is obtained. This test is uncomfortable. It can be omitted if sensory impairment is not suspected. The motor function of the trigeminal nerve is to innervate the muscles of mastication. I'm going to test your jaw muscles now, please. Can you clench your teeth tight? Keep clenching. I can feel the temporalis muscle contracting. And again, please. I can feel the masseter contracting. Can you open your jaw now, please? The pterygoid muscles open the jaw in the midline. Could you keep it open for me? The pterygoids are strong and I should not be able to overcome this movement. Can you move your jaw from side to side? If the right pterygoid muscle is weak, the jaw will deviate to the right, and if the left is weak, it will deviate to the left. The facial nerve innervates the muscles of facial expression and buccinator. I'd like to test your facial muscles now. Could you raise your eyebrows fully, please? And we're looking for wrinkling of the forehead due to contraction of the frontalis muscle, and this should be symmetrical. Can you now screw your eyes tight together? We're testing the orbicularis oculi muscle, and I shouldn't be able to open the eyes. Thank you. Now, can you smile like this, please? And I'm looking for symmetry of the smile and equal action of the orbicularis oris muscle. Now, can you blow out your cheeks? This is a function of the buccinator muscle. I press gently and see if there's any incontinence of air and escape of air from the mouth. Thank you. The eighth nerve, the vestibulocochlear, has auditory and balance functions. I'm going to test your hearing. I'm going to cover one ear and whisper a number in the other. Would you tell me what the number is, please?
36.
Yeah.
43.
Thank you. If I detect any hearing deficit, I would move on to the tuning fork tests. I'm going to do some tuning fork tests. This is the Weber's test. Can you hear that vibrating?
Yes.
Does it sound louder on one side or the other?
It's the same on both sides.
That's normal. I'm now going to do the Rene test. Can you hear that vibrating?
Yes.
Please will you tell me when it stops?
I can't hear that.
Can you hear that?
Yep.
That's a normal Rene test. I would now go on to repeat the test on the opposite side. Both of these tests rely on the fact that normally air conduction is better than bone conduction. If the air passages are blocked, then air conduction will be reduced, and this is conduction deafness. If the auditory nerve is affected, then both modalities will be reduced, and this is sensory neural deafness. The bulbar nerves are conveniently examined together. Now I'm going to test your throat and mouth. First of all, could you give a loud cough, please? Okay. This tests the vagus nerve. Now I'm going to test for articulation, which involves coordination of tongue, teeth and lips, and requires the facial, vagus and hypoglossal nerves. Could you say the days of the week?
Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday.
Thank you. What I'd like to do now is to examine the back of your throat. Could you open your mouth wide for me? Can you say ah?
Ah,
And again, please.
ah.
Thank you. The soft palate should move upwards essentially to protect the nasopharynx when the patient swallows. If there is palsy, the soft palate is pulled to the stronger side. The gag reflex is elicited by gently touching the posterior pharyngeal wall on each side and results in a gag response. It is uncomfortable and not usually tested in the conscious patient. It requires both cranial nerves 9 and 10 for afferent and efferent roles respectively. The 12th nerve, the hypoglossal, innervates the motor supply to the tongue. I'm going to examine your tongue. Could you open your mouth for me? Could you protrude your tongue? Can you move it from side to side? Now can you push your tongue against my fingers? And can you do it on the other side, please? Thank you. The accessory nerve innervates the sternomastoid muscles and the upper fibres of the trapezius. I'm going to test your neck and shoulders. Could you shrug your shoulders for me, please? I'm looking for symmetrical elevation of the shoulders by the trapezius muscles here. Next, could I get you to turn your head against my hand? And I'm looking here at the sternomastoid muscle. If we could do it the other side, please. Could you turn your head against my hand again? And again, we're looking at the sternomastoid muscle here. Okay, that's all I need to examine. Thank you.
जी क्लास आप इधर ही हो? हाँ जी, वीडियो से क्रेनियल नर्व्स एग्जामिनेशन की आपको समझ आई है? सेंसरी सिस्टम हमने कर लिया, मोटर सिस्टम हमने कर लिया, ठीक है, और रिफ्लेक्सेस हमने कर लिए और मेंटल स्टेटस एग्जामिनेशन हमने कर लिया। ठीक है, एक दफ़ा वो वीडियो देख ले दोबारा, ये वाली नहीं जो पहले वाली थी। मोटर सिस्टम देखिए मेरा।
This video presents examination of the motor system, which includes assessment of body position,
आवाज आ रही है?
involuntary movements, muscle bulk, muscle tone, strength, and coordination, and testing of the reflexes, which assesses both motor and sensory functions. In this video, you'll see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings in patients, or you may discover normal variations or abnormal findings. Begin the examination of the motor system by observing the patient's body position at rest and during movement.
I'll move these up for a minute.
Also, watch for involuntary movements.
Can I see your hands?
Next, assess muscle characteristics, beginning with muscle bulk. To do this, carefully inspect the muscles of the shoulders, arms, hands, thighs, and legs, noting any atrophy.
Let me do all the work here.
Then evaluate the patient's muscle tone or resistance to passive stretch. Encourage the patient to relax. Then take one hand in yours and, while supporting the elbow, flex and extend the patient's fingers, wrist, elbow, and shoulder in one coordinated movement. The patient's arm should move easily and smoothly with little resistance. Repeat on the other side.
Once again, let me do all the work.
To assess muscle tone in the legs, extend the patient's leg at the knee and move the foot up and down at the ankle. Note the patient's resistance to your movements. Assess muscle strength using force compatible with the patient's strength. Usually, the patient's dominant side is stronger than the non-dominant side. Begin by testing flexion and extension at the elbow by having the patient pull and push against your hand.
Straighten it out. Push away. Bend your fist back.
Next, test extension of the wrist.
Make a fist. Bend your fist back. Around my fingers.
Now test the
Squeeze as
patient's
hard as
grip.
you can.
Cross your middle and index fingers to protect them. Then ask the patient to squeeze as hard as possible while you try to remove your fingers. Normally, you should have trouble removing them. Continue testing muscle strength by asking the patient to turn his palm down and spread his fingers. Check abduction by trying to force them together.
Relax for a second.
Then test opposition of the thumb. To do this, ask the patient to try to touch the tip of his little finger with the thumb while you resist the movement. Assess muscle strength in the legs.
Relax.
Test hip flexion by placing your hand on the patient's anterior thigh and providing resistance.
Relax.
Then test hip extension by placing your hand on the patient's posterior thigh and providing resistance.
Push your thigh down against my hand.
To test hip abduction, place your hands firmly on the table outside the patient's knees. Ask him to spread both legs against your hands. To test hip adduction, place your hands between the patient's knees and ask him to bring his legs together. Note the strength.
Try to lift your foot off the table.
Continue by testing muscle strength at the knee. To assess extension, support the patient's knee in flexion and ask him to straighten his leg against your hand.
Try to lift this foot off the table.
Note the strength and compare it with the other side.
Relax. Don't let me lift this foot off the table.
To assess knee flexion, shift your hands, but leave the patient's leg flexed at the knee. Then ask the patient to keep his heel on the table as you try to straighten the leg by pulling it upward. Again, note the strength and compare it with the other knee. Finally, test dorsiflexion and plantar flexion at the ankle by asking the patient to pull up and push down against your hand. All of these tests can also be performed with the patient seated and holding on to the table for support. Hip flexion, hip abduction, hip adduction, knee extension, knee flexion, ankle plantar flexion, and ankle dorsiflexion. To assess coordination, you'll evaluate rapid alternating movements and point-to-point movements. Begin by assessing rapid alternating movements. To assess the arms, show the patient how to move his hands. Observe the speed, rhythm, and smoothness of the movements. The patient's dominant hand may be better coordinated.
Using your right hand, I'd like you to
Now ask the patient to tap the distal joint of his thumb with the tip of his index finger as rapidly as possible. Again, observe the movement's speed, rhythm, and smoothness.
to the tip of my
Next,
finger.
assess point-to-point movements. Do this several times, moving your finger so that the patient has to change directions. Observe the smoothness and accuracy of pointing. Clumsiness and overshooting with this movement suggest cerebellar disease. Then, with your finger in one place, ask the patient to point to it, raise his arm, and lower it to touch your finger. After several times, have the patient do this with his eyes closed. Inaccurate pointing with the eyes closed suggests a loss of position sense. Repeat on the other side. To assess leg coordination, ask the patient to tap your hand as quickly as possible with the ball of each foot. Note any slowness or awkwardness. Compare size. The feet normally perform less well than the hands. To test point-to-point movements of the legs, ask the patient to place one heel on the opposite knee and then run it down his shin to the big toe. The patient should be able to do this smoothly and accurately. Note any tremor or awkwardness. Assess both legs. Continue the examination by observing the patient's gait, which provides information about coordination, position sense, and muscle strength.
Walk slowly across
सर
the
वो ऑक्स केबल
As the
पड़ी है आपकी
patient
गाड़ी में
walks, observe his posture, balance, arm swing, and leg movements. The gait should be relaxed and balanced with easy alternating arm swings. The face and head should lead the rest of the body on turns.
ओ छोटा सा काम है
Next, ask the patient to walk heel to toe in a straight
चलो कोई
line.
बात नहीं
This kind of
Sir, मैंने
feat,
पता
also
है।
called tandem walking, assists
तानू क्या
cerebellum
पता
function
चला?
and position sense. You
हाँ
have the
सुबह
patient
टक्कर
walk
आया
on
वो
his
मिठाई भी
toes
मैं
to test the
गिफ्टी भी मैं
strength
कि
of
शायद
plantar
थोड़ी तक भी
flexion,
किसी की गालो
and on his
वो सारे
toes to
बड़ी
test
गिफ्ट मिल गया एक
dorsiflexion
किस्म
at
का
the
जबरदस्त
ankles.
किस्म
These actions also
का
test
वो
balance.
अच्छा बस देख लो
Next,
ये फिर
ask the
एक
patient to
गड्डियां
hop
वाले
in
ही जान
place,
लेने की गड्डी
first on one
अच्छी
leg
चीज
and then
थोड़ी
the
ना
other. This
हाँ
ability
वो
indicates
सर
an intact motor system in the legs,
हाँ एरिगेशन
normal
ऑफिसर की
cerebellar
चली हुई है
function,
ये
and good position
और
sense.
8 मॉडल है वाटर थ्रोइंग
I
इंजन
want you to stand just a little.
ठीक है
Finally,
ये
ask the
मिली है
patient to
अपन
do a shallow
4
knee
45
bend, first on one leg and then on the other.
तोहफा वही ना वो कोई टच नहीं है कोई मच नहीं है लाहौर का है हाँ टोकन पेड लाइफ टाइम वो सर जबरदस्त है मैं 1000 रुपए का पेट्रोल पपाया है तो सीधे किधरों से ले दे हैं चलो इंशाल्लाह मुलाकात होती है मैं ऑक्स हुक्म हुक्म जी 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 मुझे दे दी मैं आपको कर देता हूँ आप कर दें ठीक है ओके ओके सर अल्लाह हाफिज़ हेलो हाँ जी ओए हेलो कह रहा हूँ मैं समझा फोन में अच्छा हाँ जी स्टूडेंट्स मोटर सिस्टम देख लिया हुई अंडरस्टैंडिंग ओके आपका डाटा तो नहीं लगता इसमें सेंसरी सिस्टम देखेंगे आप
This video begins with a brief overview of health history taking, followed by examination of the sensory system, including assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Anatomy of reflexes, grading reflexes, and assessment of reflexes. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the nervous system and specific to the sensory system and reflexes include numbness or abnormal or loss of sensations, and increased sensitivity to pain. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. To prepare for the sensory system examination, let's review its basic components. The sensory system includes the sensory receptors and nerves, sensory tracts in the viscera and limbs, the spinal cord, the thalamus, and the sensory cortex of the brain. To help localize neurologic lesions, the body may be mapped into dermatomes, which are skin bands innervated by sensory roots from different levels of the spinal cord. When assessing the sensory system, plan to evaluate the patient's sensations of pain, temperature if indicated, light touch, vibration, position, and discrimination. Begin the sensory examination by assessing pain sensation in arms, legs, and trunk. To do this, first warn the patient, then use the sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable tool. Ask the patient to close his eyes. Then, starting with the arms, test scattered areas, occasionally substituting the blunt end for comparison between sharp and dull. Compare sides and distal and proximal areas. Continue the evaluation of pain sensation with the legs.
Sure. Dull. Sure.
Next, test the anterior trunk.
Now I want to hold your gown down. Just scoot up a little bit here. Pull your arms out of it. Okay, put your arms right back here at your side. Same thing, just tell me sharp or dull.
If you detect any abnormalities, evaluate the posterior trunk. If pain sensation is abnormal, test the patient's response to temperature.
Very good.
Next, assess light touch with a cotton wisp. Check the patient's arms and legs.
All right, close your eyes again. Now I'm going to touch you with this cotton swab to check light touch. If you feel it, you say now. Are you ready?
Yes. Now. 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 Now.
Then check the
Now.
patient's trunk.
Now.
Does it feel the same
Compare sides.
here and here?
Same.
Is this side the same as this side?
The same.
And compare distal with proximal areas.
Same.
And this the same as this?
Same.
Next, assess vibratory sensation using a lightly vibrating low-pitch tuning fork.
All right, I'm going to test vibratory sensation next. Close your eyes again.
Have the patient close his eyes, then place the vibrating fork firmly over the finger pad
What do you feel?
and ask the patient to tell you what he feels. Ask the patient to tell you when the sensation stops. Then stop the vibration.
Did it stop?
Okay,
Now test the patient's other hand.
over here.
Normally, vibratory sensation is intact distally. If it is diminished, proceed to more proximal areas, such as the forearm. When assessing vibratory sensation of the lower extremity, start with the big toes. Compare size. If vibratory sensation is diminished, check more proximal areas. Keep in mind that distal vibratory sensation may normally decrease with age. For the next part of the exam, test position sense.
Next, I'm going to test position sense in your feet.
Hold the sides of the patient's big toe with your thumb and index finger. Avoid touching the other
Move
toes.
it up,
First, move the toe up and down,
left.
identifying each position as the patient watches.
You close your eyes and tell me
Next,
which direction it goes.
ask the patient to close his eyes and identify the direction of motion.
Left.
Move the big toe up and down in an irregular sequence. Then compare with the big toe on the other foot.
Same thing. Are you ready?
Yes.
Here it comes.
Up. Down. Right. Left.
In a similar fashion, Again with the patient's eyes
Close your
closed.
eyes.
Test position sense in the upper extremities using a finger on each of the patient's hands.
Down. Left. Right.
Finally, test discriminative sensations by assessing stereognosis or object identification, which is the primary test. If necessary, also test number identification, 2-point discrimination, point localization, and extinction. You will perform each of these tests with the patient's eyes closed.
Keep your eyes closed. Now hold out
To
your
test
right.
stereognosis, place a familiar object in the patient's hand and ask him to identify it.
Feel that object and try to identify it.
It feels like a coin.
Good.
Repeat the procedure on the other hand using a different object.
Feels like a key.
Good. You can open your eyes now.
To test graphesthesia, or number identification, use a blunt object to draw a large number on the palm using a single continuous stroke.
Now I'm going to test number identification. Close your eyes. And on the palm of this hand, I'm going to write a number facing you, like on the chalkboard. You tell me what it is.
The number should face the patient, not the examiner.
3.
Right.
Test one palm, then the other.
Now the same thing in this hand. Tell me what this number is.
A 5.
2-point discrimination is tested by asking the patient if his finger pad has been touched in one area or two. Using 2 ends of an opened paper clip or the ends of 2 pins, repeatedly touch the patient's finger pad with the 2 points at the same time
Another test of
and with
sensation.
1 point occasionally. Be careful not to cause pain.
Is this paper clip? I'm going to touch
Ask the patient to identify if he's being touched with 1 or 2 points.
2.
Then reduce the distance between the points
Close your
so
eyes.
that you can determine the minimum distance at which the patient can identify 2 points. On the finger pad, the distance should be less than 5 millimeters.
2. 1.
I'm going to do another test of sensation now. Let me hold
To
you
test
down.
point localization, touch a point on the patient's skin. Then ask him to open his eyes and point to the place touched.
Put your hands right here. I'm going to touch you on a part of your body with your eyes closed. After I do, then you open your eyes and point to where I touched you. Are you ready?
Yes.
All right, close your eyes. Okay. Where did I touch you? Close your eyes again.
This test is especially helpful on the trunk and legs.
Where did I touch you? Okay, close again. Where did I touch you? Now I'm going to touch you on your left side, your right side, or both. And you tell me whether it's left, right, or both.
Okay.
Ready?
Yes.
Close your eyes.
To test double simultaneous stimulation, use your fingertips to provide stimulus on either one area of the patient's body or in 2 areas simultaneously. Normally, the patient should be able to identify whether your stimulus was on one side or on both sides.
Both.
Good.
Before we assess the deep tendon reflexes, let's see how and where they occur. Deep tendon reflexes are involuntary monosynaptic cord reflexes arising from the stimulation of partially stretched muscle fibers. This sudden additional stretching sends impulses along afferent nerve fibers to synapses in the spinal cord. Then efferent nerve fibers carry the impulses back to the muscle fibers, causing them to contract. Interruption of these monosynaptic arcs anywhere along their paths will cause loss of the reflex. Each deep tendon reflex corresponds to a specific spinal segment. The ankle reflex primarily relates to S1 and L5. The knee reflex to L2, L3, and L4. the brachioradialis to C5 and C6, the biceps reflex also to C5 and C6, and the triceps reflex to C6 and C7. Note that these ascending reflexes follow the numerical order 1 to 7, which may help you remember them. When assessing deep tendon reflexes, grade them on a scale from 0 to 4+. A grade of 0 reflects the complete absence of movement. 1+ indicates a somewhat diminished reflex that shows movement only with reinforcement. A 2+ reflex shows greater movement than 1+ and is an average normal response. A 3+ reflex is brisker than average, but not necessarily abnormal. A 4+ reflex is a very brisk hyperactive response. It is accompanied by clonus, a rhythmic oscillation between flexion and extension. Hyperactive reflexes suggest central nervous system disease. Begin assessing deep tendon reflexes by testing the biceps reflex. The patient's arm must be relaxed, partially flexed at the elbow, and positioned with the palm down. To stretch the muscle, depress the biceps tendon with your thumb or index finger. Strike your thumb or finger briskly with the reflex hammer. You should feel the biceps muscle contract and see flexion of the forearm. Here you see a 2+ response. To assess the triceps reflex, flex the patient's arm at the elbow with the palm toward the body and pull the arm slightly across the body. Strike the triceps tendon above the elbow. Watch for contraction of the triceps muscle and extension at the elbow. Here you see 2+ responses. To elicit the supinator or brachioradialis reflex, the patient's forearms should rest on the lap with the palms down and externally rotated slightly. When the patient is ready, strike the radius 1 to 2 inches above the wrist. Observe for flexion and supination of the forearm. Again you see 2+ responses. If you need to accentuate or reinforce arm reflexes, ask the patient to clench his teeth throughout the testing.
Now I want you to clench your teeth together hard when I say, just as I hit the reflex. Ready? Clench your teeth. Relax.
To test the knee reflex, locate the patella tendon in the patient's flexed knee. Briskly tap the tendon just below the patella. Feel for contraction of the quadriceps and look for extension of the knee. This patient exhibits a 2+ response. To test the ankle reflex, extend the patient's legs somewhat at the knee, dorsiflex the ankle, and strike the Achilles tendon. Feel and watch for plantar flexion. A 2+ response is seen. Repeat your assessment of knee and ankle reflexes on the opposite side. Dorsiflexion of the big toe, or a positive Babinski's sign, is a pathological response which, as simulated here, manifests itself in dorsiflexion or upgoing of the big toe in conjunction with fanning of the other toes. To test for plantar response, stimulate the lateral aspect of the sole of the foot from the heel to the ball, curving medially across the ball. Use the lightest stimulus that will provoke a response. Note this patient's normal response, plantar flexion or downgoing of the toes. If the leg reflexes are symmetrically diminished or absent, use reinforcement.
I want you to put your hands together like this. When I tell you to pull, then pull hard. But wait till I say.
Have the patient lock his hands and pull just as you test the reflex. If leg reflexes seem hyperactive, test for ankle clonus. To do this, move the foot up and down a few times, and then sharply dorsiflex the foot. While holding the foot in dorsiflexion, look and feel for sustained rhythmic oscillations. A few beats may be normally present. For a patient who cannot sit up, all of these tests can be performed with the patient lying down. Biceps reflex, triceps reflex, brachioradialis reflex, knee reflex, ankle reflex, plantar response, and ankle clonus.
I want you to lie back on the table now, please.
To test the abdominal reflexes, place the patient in the supine position. Lightly but briskly stroke each side of the abdomen above and below the umbilicus. You should see contraction of the abdominal muscles and sometimes deviation of the umbilicus toward the stimulus. If you suspect meningeal inflammation, test for meningeal signs. With the patient lying down, place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. There should be no resistance or pain. As you flex the patient's neck, watch his hips and knees. Normally, they should remain relaxed and motionless. Hip and knee flexion with this maneuver is a positive Brzezinski sign. Finally, flex one of the patient's legs at the hip and knee, and then straighten the knee. This action normally produces discomfort behind the knee during extension, but should not cause pain. Pain and resistance to knee extension is a positive Kernig sign. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include sensory, pinprick, light touch, position, and vibration intact. Reflexes, 2+ and symmetric, with plantar reflexes downgoing. To summarize, the examination of the sensory system includes assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Examination of the reflexes includes assessment of the biceps, triceps, brachioradialis, knee and ankle reflexes, and assessment of the plantar response, or Babinski's sign.